Please use the raised hands. That's the easiest way for me to see you, as we're going to be showing a fair number of slides. All right, let's dive into the votes. Okay, just to note that the patient populations do shift a bit, especially when we talk about pembrolizumab. So for the questions 1 through 5, the patient population of record, if you will, is adults with BCG unresponsive, high risk, NMIBC. I'm not going to read all the rest of it because you know what that means now. So it's the entire population, if you will. So the first voting question is going to be, is the evidence adequate to demonstrate that the net health benefit of nadofaragene is superior to that provided by best supportive care? Yes or no? And I'm just going to start for most of these by asking the person from the research team to briefly summarize the main findings and the ICER ratings. So Steve, this would be you on this one. Steve Atlas, if you can just again, and if you will, also if there's a specific table or two that they should refer to in the evidence summaries, help the CEPAC folks find that.
Yeah, I apologize with this. It's hard for me to have the evidence summary page, but I believe it's page 9 for nadofaragene with figure 2, which presents the primary evidence for the phase 3 single-arm trial that looks at outcomes over a 1-year period of time in patients with both groups, population 1 and 2, showing response rates higher for the Ta/T1 disease compared to the carcinoma in situ only, about 50 to 70%, and then decreasing in terms of having recurrence or progression over time. And as mentioned, we highlighted in, and I think Dr. Mitchell highlighted the comparative data suggesting a 20 to 30% historical rate as the FDA comparator. And in terms of safety, as highlighted, the rate of discontinuation due to side effects was low for nadofaragene, I believe 2%.
Right. Now, to be fair, I think the way you framed it, the FDA has that threshold. I'm not sure comparator is the right word. It's more that's the degree of the minimum threshold that means that you have a patient benefit. I think that's what they were really stating there, that it's almost like progression-free survival. They set some kind of threshold above which they imply that there is enough of a benefit to patients to merit consideration. I should have noted also that we continue to have our clinical experts, John and Aaron, and also our patient experts, Stephanie and Karen, so that as these issues come up, we will, especially when we get to the potential other benefits, et cetera, we'll be referring a lot to them to get some guidance. All right, so Steve, anything else you wanted to add? If not,
I think just my comments about long-term data for these is relevant, as I commented in the last with Dr. Lowton, in terms of, while there is some evidence that there's stability over time in some patients, there's still a lot of uncertainty about whether there is a loss of cure if you wait too long, and only long-term data in a larger number of patients will be able to assess that.
Okay. And again, we're headed towards questions in which we'll compare nadofaragene and Opertuzumab to other agents. So when you see best supportive care, you can interpret that in some ways almost like the FDA does, but it's kind of surveillance. No, we're not implying that there's another active treatment to which you're comparing it in this question. Does the CEPAC, do you guys have any questions about the evidence that you'd like to raise at this point in advance of the vote? While you're thinking, if there is any, I'll go ahead because Steve Atlas has raised this question a couple of times, and it may come up in the policy roundtable too. But is it a potential risk to patients to have them take a drug that would have a higher response rate, but in some way, potentially, is there a potential that that would decrease their risk of a cure with cystectomy later on in the course of their treatment? Is that something that the clinical experts or the patient experts think that the CEPAC should weigh in their thinking on this kind of question?
I don't know if Dr. Mitchell or Dr. Gore would want to comment on that. I can give what I've heard, but I'll turn to the experts if they want to say something.
I think that hypothetically, those are a scenario like that and a concern like that is certainly possible, and anecdotally, it's probably the case that happens to some number of patients. But just when we start getting to like the the second and third order effects of how these drugs, if given, like would or would not affect treatment decisions down the road, I think it is a concern. It's just impossible to know how that would stack up with these drugs compared to usual care or with other agents without having the data. So I hear it. I would be very uncomfortable at estimating the magnitude of the importance of that particular consideration without knowing.
And we're not explicitly, obviously, comparing either of these agents to cystectomy. That would involve a very different kind of level of well, it'd be just a very different framework for thinking about what we're comparing. And as we've heard that for many patients, I'm sure it's most, the desire is to seek some treatment short of cystectomy at the time of diagnosis. I'm not sure what the percents are. Do the clinical experts or the patients, do you guys have a sense of what patients in this population opt for early cystectomy as opposed to bladder sparing options?
This is John Gore. Oh, sorry, go ahead.
No, go ahead, John. Go ahead, you first.
So I think it's a complex discussion. We know from some national data that about 15% of patients in this category tend to go on to cystectomy. And it tends to be a little bit oversampled for people with what we would consider to be higher risk recurrences. So things like recurrent T1 high grade muscle invasive bladder cancer, refractory carcinoma in situ, things where we are really worried about the potential cost of losing a window of curability. And so they tend to be, this is one of the challenges here is this is an incredibly heterogeneous group of patients. There are low risk, high risk recurrent non-muscle invasive bladder cancers and very high risk recurrent high risk non-muscle invasive bladder cancers. And so the cystectomy population is going to be oversampled for that. It also depends on who they see. And so I think you'll find that patients who are seeing high volume bladder cancer providers, patients who are being seen at a comprehensive cancer center with experienced bladder cancer teams are actually going to tend to be more likely to be considered for cystectomy. We know that cystectomy in general is an underused medical treatment, even for people with more aggressive bladder cancers. And so it's highly dependent on the provider that patient is seeing, and also some of the nuance of their clinical recurrence.
Thank you, John. Sorry, did Karen or Stephanie want to jump in?
Yeah, I just wanted to comment that, the bulk of patients are not seen in these larger institutions that have all of these wonderful experts that have so much more experience. And so, we do hear all the time from patients that they want to try to do whatever they can to avoid losing their bladder, because what they do know about it is that there are complications that are related to having a cystectomy, and certainly changes in their lifestyle and quality of life based on the type of diversion that they end up with. And then there's also complications from that as well. And quite honestly, we've lost a number of very dear friends of our organization that had 7 years of no evidence of disease and then suddenly had a metastasis somewhere else, and it was not even on the radar for people. So even then, it's never a guarantee. So I think that, certainly a lot of patients are very willing to attempt to do something different and not necessarily go the cystectomy route, particularly because they know what those outcomes might be. Like loss of sexual function, or, you know, inability to care for themselves. That's a big deal when you think about older patients.
And thank you for that perspective. This will come up again in the policy roundtable as well, but I thought I would get it out early, probably because Steve mentioned it. All right, I know we've got a number of voting questions to come, so I think hearing no others and seeing no raised hands, why don't we go back to the voting slide, please? And we will take our vote. All right. So again, is the evidence adequate to demonstrate that the net health benefit of nadofaragene is superior to that provided by best supportive care? Yes or no? And we can see the responses accumulating in the little box at the top there. We should have 12 votes. Oh, 11. Okay, we're all set then. I keep getting 12 and 11. All right, we're set. We can show the votes, please. All right, 7 yes and 4 no. If we have time, I may circle back to get a little bit of a debrief on the voting split there. But let's keep going to the next question. Framed exactly the same, but on Opertuzumab, is the evidence adequate to demonstrate that its net health benefit is superior to that provided by best supportive care? Steve, you got the right page and the right table before. Can I ask you to do it again?
Oh, no. This is the same issue for Opertuzumab, which is figure 3, I believe on page 9. And again, showing for both groups, the cis and the T1 only. Similar rates for both of them. For the T1 only, about 70% at 3 months, maybe a little bit lower for at the cis only, and then again, sort of recurrences over time, as mentioned. As I also discussed, the side effects are similar in terms of I think 4% discontinued due to side effects for Opertuzumab, and limited long-term outcome data, as we've spoken about. The one other caveat is unrelated, is just the dosing for this is more frequent than for nadofaragene.
We will definitely come back to talk about that aspect in the policy roundtable, or the potential other benefits, I should say. Okay, any questions about the evidence base for Opertuzumab from the CEPAC? Otherwise, I think that the general issues around the single-arm trial, et cetera, are similar with nadofaragene. So why don't we go ahead and vote on this one, please? Okay. Is the evidence adequate to demonstrate the net health benefit of Opertuzumab superior to best supportive care? Okay, please show us the results. And we've got 8 and 3. All right. We'll come back again to talk about that if there's time. And let's keep going. Okay. So now we're going to start to do a little bit of head-to-head, if you will, even though there are no head-to-head trials. We all know that doctors and patients need to think a bit about option A versus option B with whatever evidence is available. So the question here is the evidence adequate to distinguish the net health benefit between nadofaragene and Opertuzumab? Steve, we remember that this was rated an I for insufficient. Is there anything else you wanted to say other than the fact that there are no trials? I mean, even trying to do an indirect comparison, maybe you can just mention again some of the differences in the trials or the patients that made that difficult.
Right. So we were struck by the fact that there is no control group, a placebo group in either of these to be able to adequately say what that best comparative would be in these trials. The populations were similar but not identical. There were, as mentioned, some differences in how outcomes were assessed at 12 months between nadofaragene and Opertuzumab. But our focus really was the lack of comparative data did not permit us to directly compare these two drugs.
All right, any questions from the CEPAC? All right, we see this commonly. We'll talk about it in the policy roundtable about whether this is what we want to have available for patients and doctors, and if not, how we get there. But let's go ahead and take the vote. All right, is the evidence adequate to distinguish the net health benefit between nadofaragene and Opertuzumab? Go ahead and vote. We already have all 11. Thank you. Go ahead and see the results. Okay, unanimous no. Thank you. Let's move to the next voting question. All right, we can pass this one. This was an if, and it wasn't. All right, so here we are. So here's another comparison that doesn't exist in a head-to-head trial. Is the evidence adequate to demonstrate that the net health benefit of nadofaragene is superior to that provided by gemcitabine with or without docetaxel? Steve, why don't you again just summarize the state of the ability to compare those two?
Yeah, so we felt it based on information from our experts that we wish to examine the quality of the data for these chemotherapeutics. As I highlighted, the populations were larger differences between these older trials. The outcome assessment was not identical, and thus any direct comparison of the outcomes between nadofaragene and these older trials we weren't able to do. There were some that were prospective for gemcitabine alone, but the key gemcitabine with docetaxel, we highlighted that is a retrospective study, and thus the ability to compare outcomes directly is much more limited for that population.
So before I ask the clinical experts or the patients or others for questions, the public comment from, forgive me, I forget his name, either the CEO or the representative from Sesson Bio, I think he made reference to a meta-analysis that suggested that data on his treatment was far superior to gemcitabine. And so therefore, even if it hasn't been directly compared, let me just be devil's advocate. There is enough evidence to say that just given the magnitude of the difference that you could say that they're different. Did you have a comment about that in particular, or I can ask others if they're aware of that study? I'm sure we are, but.
I can ask Dr. Goran Mitchell, but we were aware of no evidence of a indirect meta-analysis that compared these older drugs with the newer agents or even among themselves. So I think, what we were struck by is that there is some efficacy to these older drugs that were pointed out by our experts, and we found in older studies. The side effects that I didn't mention are harder to ascertain in these older studies, but we felt that patients could consider these, but we were not able to really directly compare them to these newer agents, either nadofaragene or, as we'll get to momentarily, for Opertuzumab. Dr. Gore, Dr. Mitchell, I don't know whether you all would comment further.
All right. I'm not seeing a desperate desire to jump in on this from either one of them. So it could be that Aaron, are you able to hear us?
Yes.
Okay. For some reason, you were, sorry, just the way your eyes were moving, I thought you were looking to try to figure out how to get in. Okay, then let's go ahead and vote on this one. All right, is the evidence adequate to Oh, I'm sorry. I thought this one was a distinguish. It's not. It's to demonstrate whether it's better. So is the evidence adequate to demonstrate here that the net health benefit of nadofaragene is superior to that provided by gemcitabine with or without docetaxel? Please go ahead and vote. Looks like most of you have. We've just got one more now. Okay, thanks. You can see the results. All right, 10 and 1. Okay, near unanimity. Let's move on to the next question, which is the same, except swapping in the question with Opertuzumab instead. So here we're asking whether there's adequate evidence to say that Opportumab is superior to the net health benefit provided by gemcitabine with or without docetaxel. And again, Steve Atlas, there's really no difference here in terms of the evidence that is available to help try to make that distinction. Is that true?
It is the exact same issue, yes.
Okay. Then why don't we go ahead and vote again, because I really don't think there is any separate issue on this one. All right. Yes or no, is it adequate to say that Opertuzumab is better than gemcitabine? Okay, we can see the results. Okay, 11-0. We're making good time, which is great because we're going to have time as we want to have for the potential other benefits and contextual considerations. I think we might have one more or two more clinical votes first. Okay, so here's another comparative question. And now we've slightly switched the patient population, and that's because of the label for Pembrolizumab. It's only in this part of the NMIBC population. You can see it up above. Is the evidence adequate in this population to demonstrate that the net health benefit of nadofaragene is superior to that provided by systemic Pembrolizumab? Yes or no? Steve, can you summarize the evidence?
So the evidence presented that's relevant for this one is figure 2 for nadofaragene on page 9 and figure 4 on page 10 for pembrolizumab. It would be the blue bars for both of them, which represent the patients with carcinoma in situ as the relevant population 1 comparison. We rated that this, again, the same issues as we previously discussed about both of these being single-arm trials without any placebo or comparator, and slight differences in the study populations, and again, in how outcomes were assessed, led us to a rating of I, where we were not able to have insufficient evidence to say that one was better than the other. In terms of side effects, as presented, I don't have that table, but as I presented, the side effects for the systemic therapy are greater, or there's higher reports of both side effects as well as discontinuation. But again, slightly different populations. And then the immune side effects are present for pembrolizumab, which we would not expect for the installation therapy in this case. The long-term outcomes, there is, as we presented, some data to suggest that patients who do respond to pembrolizumab will remain stable over a longer time period. The caveat for that is that this is a very small number of patients. And to be able to say whether that will be seen in a larger number of patients in routine practice, we felt that was an uncertainty as well.
And just, is this the one where the outcomes, the bladder biopsies were done in different ways to try to assess the effectiveness? Is this one of those comparisons where that was done differently?
Yes. So just to clarify, for nadofaragene at 12 months, that trial required a blind biopsy if there was nothing seen on cystoscopy. That was not the case for either Pembrolizumab or Opertuzumab at 12 months. Outcomes after that were subsequent outcomes in recurrences or progression were ascertained in a similar fashion.
Okay. What may seem a minor difference, it's hard to know how much a blind biopsy would turn up versus someone going in and looking and saying, I don't see anything, so we're okay. It's hard to know, obviously, the impact of that, but it is one of the complicating factors in making a comparison.
So it would be relevant if you were focused on the 12-month outcomes between these drugs.
Right.
You would have to have a little bit of a caveat regarding them.
Yeah. Any comment on this question from the clinical experts or the patient experts? Okay. I think we're good. Then any questions from CEPAC? I see. Okay. All right. So this is worded also because Pembrolizumab is an existing treatment. We've worded it. Is the evidence adequate to demonstrate that nadofaragene is superior to that provided by systemic Pembrolizumab? And please go ahead and vote. All right. We're already done. Thank you. Let's see the results. All right. I had a feeling we were headed that direction. Thank you very much. And now the same thing with Opertuzumab. Steve, anything different about this comparison compared to what we were just speaking about?
The only would be that at the 12-month, if the outcome assessment for Opertuzumab and Pembrolizumab both were done in a similar fashion with cystoscopy and urine cytology. Neither of them required a biopsy. Otherwise, the issues are identical.
Okay. As were their complete response rates at 12 months. Okay. Any questions about this, Eric? Yeah.
Yeah, can I ask a question about in considering this particular question, right? In terms of net health benefit, am I interpreting the harms table correctly, in which NATO has a significantly lower probability of serious adverse events than the comparisons? Is that, I mean, can I make that sort of comparison, or is that totally unfair? And because I'm thinking about putting that into my calculus in considering net health benefits of the harm side of this, given that the outcomes are maybe lackluster in the magnitude of the difference between them. Is that, like, somebody nod or tell me that I'm not looking at this the right way?
I'll look to the experts or David, but my perception was that the qualitative for Opertuzumab and nadofaragene in terms of adverse events is that they are comparable. Given the small number of patients in these trials,
okay,
these would not be considered statistically significantly different. The nature of the adverse outcomes reported and the discontinuation rate suggests that they're fairly similar. I don't know if Dr. Gore has any experience where he could directly comment on that.
I don't have any personal experience delivering either of the two therapies that we're discussing. I do agree that the AE profile seems to suggest a lower AE rate for nadofaragene, but I also agree that they're within a similar range of events.
Okay, all right. Thank you.
Okay, let's go back and vote.
Could I just make a comment?
Oh, I'm sorry. Yes, Karen.
I'm sorry.
Sorry, Stephanie.
I hate to be going back to this, but back onto the adverse events. The table for nadofaragene reports out that grade 3 to 5 AEs the occurrence rate is 3.8%, whereas for Opertuzumab and Pembrolizumab, it was 21% and 29%. So I don't know, to me, as a layperson, that's, you know, quite a difference between nadofaragene and Opertuzumab and Pembro.
I think it's a very fair point. And actually one of my very first questions in the policy roundtable was going to be, how are patients and doctors going to talk about which treatment to use? What's really going to stand out in their minds? What I'm hearing is the intersecting issue is whether the way that those data were gathered raise enough questions about how kind of stable the estimates are and how fair it is to compare across the different kinds of studies. So the findings themselves do suggest a gap, but whether that's going to be, if you randomized patients and did it that way, it'd be so much easier to know for sure.
I would just also, though, come back on Pembrolizumab in particular, as opposed to the comparison between NATO and Opertuzumab. We have lots of data on Pembrolizumab in other settings. We know that it causes important immune reactions that can be quite serious in some people. And it would be very surprising if these instilled therapies had side effects similar to the autoimmune reactions caused by Pembrolizumab. So that's an important side effect of Pembrolizumab that just isn't likely happening with these instilled therapies. On the other hand, Pembrolizumab also has efficacy in more advanced bladder cancer, and so it's possible that it has preventive efficacy that we're not able to really recognize here. So it just goes to show the level of uncertainties we have here as we're looking at net benefit of these therapies.
Yeah, thanks, David. I just in my calculation, when I think about the net benefit, I want to give full consideration to the harm side, not just the disease-free survival or whatever we're calling it in this case. So just thank you.
Very good. All right, any other questions or comments on that point? That was very helpful. All right, let's go back to the voting question then. And let's continue the voting. So again, is the evidence adequate to demonstrate the net health benefit of Opertuzumab is superior to that of systemic Pembrolizumab? Okay. All right, 10 no and 1 yes. All right, onward we go. We are now entering potential other benefit land. So be relieved that you do not have to try to read this font or remember anything from this slide. It's a chance for me to describe to the audience that, again, the purpose here is that we acknowledge that there are important aspects. You'll remember it from my introduction, things you could call benefits beyond health or special priorities. And we are going to be voting on them one at a time. So we're going to be voting on a row. And a 1 vote will suggest relatively lower valuation of a treatment, and a 3 will suggest relatively higher valuation of a treatment on whatever spectrum you'd like to consider. And so a 2 is kind of a neutral intermediate position. And so that's the way it's set up. And if we go to the next slide, you can start to see what these look like. Okay, now some of these issues are related more to the condition and really not to the treatment per se. And so for some of these questions, we're going to be able to vote as to how they relate to both of the newer treatments, nadofaragene and Opertuzumab, and this is one of them. So this one is, I'm going to read the number 1 box and the number 3 box. In the number 1 box, it says, this intervention will not differentially benefit disadvantaged or underserved community. And number 3 says this intervention will differentially benefit a historically disadvantaged or underserved community. The CEPAC members know that these questions are not cooked up specially for each treatment area. They're meant to be comprehensive, and so sometimes they don't really apply, but when they do, they can be sometimes very important. So, any questions or comments on whether this patient population is historically disadvantaged or underserved in some way?
I
Stephanie,
just have
looks
a
like you wanna
slight
jump in.
comment in.
Yes.
Yeah, I have a slight comment just about, actually how often that people who have a challenge getting in for healthcare might need to go in for the various treatments. When you look at having to go in for BCG, for a series of weeks at a time, that's a big commitment. Whereas, when you compare to nadofaragene, you're looking at 4 visits in your urologist office, not necessarily having to go to a specialty center to get that treatment. That is certainly an advantage for people that have challenges getting into healthcare. So
Stay tuned.
I think that the number of visits is important. Yeah.
Absolutely, stay tuned, because I think that's not number 3 or 4. It's one of the questions coming up, is about the complexity of the regimen and whether it's easier or harder. So we'll capture that. Aaron, I see you're raising your hand. Yeah.
Yeah. So either I've missed this every other time, or this is new, but it seems that 3 is there is a benefit. 1 is there's no benefit. So 2, I would think that like 2 would be 1 would be a harm, and 2 would be neither benefit nor harm.
No, it's more that, again, if you have in your own mind a point estimate for what the value is of these treatments, do you think that it should get more, or if there's a range for that, let's say, should it get more credit or relatively less credit based on whether it does whatever the kind of issue is? This one is not whether it's harmful, it's more, do we give it special priority because it does address a population that is historically disadvantaged?
So in other words, it's like no benefit, a little benefit, a lot of benefit.
It's kind of like on the range of whether this is a historically underserved or disadvantaged community. Is this somewhere in the middle a little bit, or is this, no, this population really hasn't had any historical disadvantages in our healthcare system, in our society, that kind of thing.
Got it.
Good. I think Tim has his hand up.
Yes,
his real hand, not his virtual hand.
And I see Reem's virtual hand as well. Go ahead, Tim.
So now that Aaron's raised that question, that now I'm struggling a little bit with this. I saw it on Wednesday as well. There is not a sort of a negative response. It's like it's going to harm people. So you're saying that that's not on this scale. So that would be really bad if it harmed disadvantaged communities. You're saying that the 1 is it's a little bit of benefit to disadvantaged communities. 2 is it's a little bit more benefit, and 3 is it's a lot of benefit. But there's not anything on the scale saying it's going to harm disadvantaged communities.
That's true. We are assuming that treatments are for a condition in a disadvantaged community or of a disadvantaged community, and therefore that's the question. It's not whether it's a harm. This does come back to the issue that we've addressed before, which is sometimes, in many ways, almost always, brand new treatments are first rolled out at academic health centers and tend to be delivered to patients who are kind of plugged in to that network and that system. And that can increase disparities of access and outcomes in some ways. This is actually not trying to get at that issue. It's more about whether the patient population itself in our country represents an historically disadvantaged or underserved community.
Reem, I know you have a question, but I was going to add, in prior conversations among CEPAC, even before this rubric, was used, lots of conversations, talked about racial minority groups, folks that live in poverty, to some extent rurality, if that's a word, or ruralness would come into play. So typically the dialogue on this question has been focused on those particular dimensions of a patient population. It's not always the case, but I just want to resurrect kind of what we've talked about in the past and maybe frame this particular issue there. Some things are very clear when we're dealing with diseases that have a very, very high health equity issue. And I think maybe we could bring it back if you wanted to talk about it on how those issues play out in bladder cancer specifically. But that's typically how we've talked about this particular line item. Hope that helps.
Reem?
Yeah, it's probably kind of similar point. So I think as I'm listening to this, what will help us answer really has nothing to do with the intervention. It's primarily the population affected, who is affected by bladder cancer, is what will help me answer here, correct?
Correct.
Okay, thank you.
Okay, let's go back to the voting question. And you can vote 1, 2, or 3. Just waiting for one more. There we go. Thank you. Okay, 5 1s and 6 2s. Thank you. Let's go on to the next one. All right, so this is also related to the condition and not to the treatments per se. And these are ways that different health systems, different countries have in some ways tried to make more empirical their discussion about the burden of illness or the need for treatment for patients. The two ways, and we've walked this through before as far as the methods, are to look at the absolute quality shortfall and the proportional quality shortfall. Again, you can think of the absolute as how much of the healthy life is lost with this condition overall on an absolute basis. A proportional one is of the time remaining for patients. So this captures in particular conditions that happen among the elderly, but of how much time you've got left, how much is lost on a proportional basis. So it allows you to think about this issue in different ways. So the first question is, does this condition represent in its current state of care a small health loss without the treatment as measured by absolute quality shortfall, or a substantial health loss without this treatment as measured by the absolute quality shortfall? And to make any kind of heads or tails of this, you need to know what the absolute quality shortfall was and how it compares to some other conditions, just to give you some kind of framing. And for that, Rick Chapman, our Director of Health Economics, wanted to invite him quickly to come in with the results and to frame them for us.
Yes, so if you look at your evidence summary, it's the next to last page, page 14, table 6.2, has the absolute and proportional quality shortfalls for this condition and for some comparator conditions. So you see in the first row there, the absolute shortfall in the next to last column is 5.7 QALYs. And so that represents of the remaining quality adjusted life expectancy for this population, how much would be lost without these new treatments. And you can see that's 5.7 QALYs. For comparison, if you look at a condition that affects a younger population, such as the last row here, cystic fibrosis, you can see the age of the population starts out at 2 years old. And as a lifelong condition leads to a very large loss in QALYs of 42.3 in terms of an absolute shortfall. Here for the NMIBC, we're looking at a 72-year-old population, so they have a much shorter quality adjusted life expectancy, about 10.6 years. And so you can see without additional treatment, they would lose 5.7 QALYs. Now, if you look at the last column there, that looks at the same shortfall, but now it puts it in proportional terms. And so rather than looking at how many absolute years of life would be lost, it's saying of the remaining quality adjusted life expectancy this population has, how much would be lost without additional treatment. And here you can see that's a 0.54, which would represent about 54% of the remaining quality adjusted life expectancy being lost. And that's, in contrast, the absolute shortfall, it's not very high in absolute terms, but because these people have a relatively short life expectancy in quality adjusted terms, that 5.7 years would represent about 54% of their expected quality adjusted life expectancy.
All right, so let's go back to the voting slide just so we can see it again and people can start to think about it. So again, 1 means a relatively small health loss without this treatment, and number 3 is a substantial health loss. And again, the basic issue is to try to capture your sense of the burden of illness, which is the usual term that's used, if there is one, to connect to absolute quality shortfall. Proportional, sometimes people call it the need, but there's debates about that. So it's different ways to think about whether we want to give special weighting to this area and the treatments that are available. All right, any questions about this right now? All right, let's go ahead and vote. 1, 2, or 3. Very good. And we get, all right, almost a normal plot there, more normal distribution. 4 1s, 4 2s, and 3 3s. All right, let's go to the next one. This is the proportional quality shortfall. So Rick already walked you through the numbers, and I think we've tried to describe certainly what the meaning is, or the distinctions between the absolute and the proportional quality shortfall. Any questions about how you're going to interpret this one? All right, let's go ahead and vote. I am sensitive about the time, so apologies if it seems like I'm going quickly. But let's go ahead and vote on this one. Okay. All right, somewhat different than the other one. 1 1, 7 2s, and 3 3s. All right, I think we're moving out of the combined questions, and now we're going to ask you questions related to nadofaragene and Opertuzumab separately. We're going to ask you the same question, but for each drug. So I think, again, we can probably move relatively quickly through here, but these are now separated because there might be specific issues related to the modeling of nadofaragene, for instance, that they're different than what we did with Opertuzumab. So this first one is just to capture your general sense about the role of uncertainty in what you think the judgments of value should be. Number 1 here says the uncertainty or overly favorable model assumptions create significant risk if the base case cost effectiveness estimates are too optimistic. And obviously number 3 is the uncertainty or overly unfavorable model assumptions creates a risk that the base case cost effectiveness estimates are too pessimistic. And a 2 is you kind of think that the base case, estimates are right somewhere in the sweet spot there. So we know there was a lot of uncertainty in this, and maybe I can just ask Dan again. I mean, I don't want you to summarize all of the different sensitivity analyses, et cetera, but would you like to make any comment on this before the panel discusses it and votes?
Yeah, sure. So I think there's 2 important considerations here. One is that the model heavily favors some of the longer term outcomes, which were highly unstable. So there's a lot of uncertainty in the model. The other is comparison to this hypothetical treatment that had a 0% complete response rate. It's unrealistic, especially when we're looking at non-CIS populations where we would anticipate seeing some response because the tumor is resected or removed, or the tumors, there may be more than one, they're removed. And so there would be some continued complete response until it grows back from the few cells that were remaining.
Okay, any other, thank you, Dan, that was very helpful. Any questions about the uncertainty as you guys are trying to assess it in this question? Yes, Eric?
Well, go ahead, Tim. I had a hand up.
I'm trying to interpret this question appropriately so I answer it correctly. It says, is this uncertainty about the base case, or is it uncertainty about the base case as well as the thing we're comparing it to? So it's only uncertainty about the base case.
Well, the base case involves a comparison.
Right.
Right? So I'm not quite sure what you're asking. It's ultimately whether you think the uncertainty in your mind is managed such that you think the cost effectiveness point estimate is where it should be, or do you think that there's kind of a risk, more of a risk that it's being pessimistic or too conservative, pessimistic or optimistic based on different assumptions made in the model?
I think I understand now. Okay.
I should probably just say one side is too optimistic and one side is too pessimistic.
So if I feel that, yeah,
certainty is the reason that you're feeling that way.
So if I feel like the model, the base model is on balance fair. It's a 2.
2.
Okay. Yeah.
Could I ask one more follow-up? I was going to ask this later. I give the modelers a lot of credit because we always make assumptions. There's always things you got to make assumptions about. And I was probably going to ask this later as well. I heard a lot of places here where you said there was a lot of data we didn't know, and so you had to plug in things. Is that correct? And so when I'm sort of evaluating the numbers you put in here, I'm struggling a little bit with trying to evaluate the results relative to what I've seen in other ICER meetings. Because, you know, and then you had the bar that went like that. So, you know, and so again, I'm not being overly critical. It's just that lack of available data out there in order to populate your model.
Yes, thank you for reminding me of potentially a third area that you may want to consider. And that's that we have very, very little information, again, about these long-term outcomes, especially where it comes to what proportion of patients receive cystectomy and when do they receive cystectomy. So there was uncertainty there as well. I think, and then, you know, just overall with the estimates, these were small studies. And there's uncertainty in the estimates, which, you know, these point estimates could result in different results if we were to have you know, better data from with more precise estimates of progression, or even knowing more about what a comparator might be.
But you're right to think of the sensitivity analyses, those tornado diagrams, and you can, how far they stretched and in which direction. So sometimes you can look at that, but again, it depends on whether you think they got the initial assumption right or whether you're swayed by that long tail in one direction or the other, which again allows you to think a little bit about that.
Steve Bradley's in the,
yes,
well, he's in the bottom of my screen.
I got it.
Yeah, I know I use the old school way to be recognized, but
it works.
And I guess another thing I think about, we don't have pricing data. You put in Pembrolizumab price in there, you know, we kind of have a, you know, a word of mouth price from the manufacturer on another. So I think that's another. That's
true. And that's why we're not going to be voting on the overall value, because that would send too strong a signal. So I would, to a certain extent, I would factor in the uncertainty around the other aspects of the model more than the price at this point. But it's very valid to point out that even changing the price a little bit might make a difference here as well. Okay, that's very, very helpful. Let's go ahead and move to the vote. I want to try to capture some of the other important potential benefits. So please vote 1 that you think, I'll just say too optimistic. 2 is you think it's best we can do and not unreasonable. And 3 is you think it's too pessimistic. All right. Nice little bell curve there. 2 1s, 7 2s, and 2 3. That's right. Yes, 2 3s. All right, let's keep going. All right, now we're going to do the same thing with Opertuzumab. And again, sometimes there are different assumptions and different levels of assumptions. Dan, would you say that there were any significant assumptions that would raise more uncertainty in the modeling of Opertuzumab than for nadofaragene?
No, the quality of the data was very similar from both studies. The only one difference between the studies, which I tried to point out in a scenario analysis, was that at 12 months, Opertuzumab the study did not include biopsy when diagnosing or when looking at recurrence.
Okay. All right. I think given that the situation is very similar, then let's go ahead and vote on this one. Thank you. You guys are being very quick with the votes. We just need one more though. Oh, I'm sorry. That's right. Rachel had to step out. Okay, we can go ahead. We're getting votes separately from Rachel. So let's go ahead and see the votes. Okay, sorry, there we go. 7-2-1. Okay. 271. All right, next. All right, so now we're going to go through, again, things separately for nadofaragene and for Opertuzumab. This one, and again, you may feel that it's not worth giving extra credit to, but some people do wish to do so. So we want to know whether you think, number one, nadofaragene represents a very similar mechanism of action to that of other active treatments, or number three, it represents a very new mechanism of action compared to that of other active treatments. Two means it's somewhere in between, but this is more of a dichotomous result, obviously. Steve, or Steve, I could ask almost any of the clinical experts as well, but just a quick comment on the newness, if you will, of the mechanism of action for nadofaragene.
Yeah, so as I highlighted in my presentation, this does represent a novel, both a novel delivery mechanism and toxin treatment for these cancer cells. So this is using a adenovirus, a viral vector, to deliver interferon into the bladder cancer cells to selectively kill them. As such, this represents a new, this is different than chemotherapy in profound ways from a mechanistic point of view.
That's good. Because our time is short, I think that was exactly what they needed to hear, just to refresh their memory. So let's go back. Any questions about it, though? I doubt there are. Let's go back to the voting slide. And please go ahead and vote. It is a very similar mechanism, or it is a new mechanism of action compared to that of other active treatments. Okay, we've got our 10 now. All right, we've got 3 number 2s and 7 3s. Good. Next is going to be the same question about Opertuzumab. So Steve, again.
So this is even a more different, this is again different than nadofaragene. Here, it's a different delivery mechanism into the cell, and the active toxin is actually from a bacteria, Pseudomonas toxin, being preferentially brought into these cancer cells, which again leads to its toxicity. So a novel mechanism, quite different from that of nadofaragene.
All right, why don't we go back to the voting question? And we'll go ahead and have you vote. 1 is very similar, 3 is new, 2 is intermediate. Okay. And we get 3 and 7. All right, moving forward. All right, so this one I need to just take a little bit of a chance to explain it again. So we're asking just about nadofaragene first off. And the question is, does the delivery mechanism or its relative complexity of the overall regimen, is it likely to lead to much lower real-world adherence and worse outcomes relative to an active comparator than we were estimating from clinical trials? Or is there something about this delivery mechanism or the relatively simplicity of the overall regimen that is likely in the real world to result in much higher adherence and better outcomes relative to an active comparator than is estimated from clinical trials? Because obviously the model tries to capture that, but the question is, in the real world, is there something about this? And this gets back, I think, to Stephanie's point around the number of visits and how that can affect, from a patient's perspective, the relative value of the treatment, but it could also improve adherence. Do either of the clinical experts have, I know you may not have used nadofaragene yet, but do you have any comment to make around the real world adherence issues related to chemotherapy or other options?
This is John Gore. I do think this is where the intensity of installation schedules has an impact. Bladder cancer does have some disproportionate intrinsic virality, just because it's a cancer with smoking associations and chemical exposure associations that tend to maybe oversample in rural communities. And so that can definitely impact sort of the real world applicability.
Okay, so nadofaragene has a much lower number of required visits than Opertuzumab, but how about gemcitabine and docetaxel?
There is a practical aspect to gem and docetaxel, which is that they're typically sequentially given in the clinic. And so there's a little bit of a workaround that's difficult to give. Oftentimes when we give that combination of chemotherapies, we're less likely to get some partnerships with our community partners in urology to deliver those chemotherapies just because of the hazardous waste concerns. And the intensity of the schedule is similar to BCG and other installational intravesical therapies.
Any questions or comments from the CEPAC on this one? Okay, let's go back to the vote.
I think, Stephanie, did you have a remark?
Oh, I'm sorry, I didn't see a hand.
Well, I was just going
Oh,
to ask, and I don't know, a lot of these trials have happened in large academic institutions. I think, isn't this something that's going to be available in a local physician practice down the road? If it's, when it's approved, is that going to help make it a little more practical for people to be able to get in for fewer visits? And I'm not sure on this. I'm just mentioning that as a concept.
Aaron or John, what do you think?
I think both will be practically delivered in a community urologist's office, very much so.
Okay, great, thank you. Let's go back to the voting slide. All right, so one is, it is something about the way it's delivered, its mechanism of action, the other aspects of it may lead to lower, is likely, I should say, to lead to lower real world adherence. And number three is that it would be easier to comply with, if you will, or to adhere to, and that could lead to better outcomes. Why don't you go ahead and vote? Thank you. We're almost. Okay, can see the results. Okay, so 7 folks voted 3 and 3 folks voted 2. Great. Next one's going to be about Opertuzumab. Now I need somebody to summarize. I don't know the schedule on this quite as well in terms of how it compares to something like the docetaxel or to Pembrolizumab. But Steve, do you want to summarize that maybe? And it was in your slide.
So it's 2 times a week for 6 weeks, 1 time per week for 6 weeks, and then every other week thereafter. We consider this, and Dr. Gore could, or Dr. Mitchell could comment otherwise, to be a more intensive regimen, more comparable to existing therapies such as BCG and the chemotherapeutics. I think Dr. Gore commented around there may be some issues with the chemotherapeutics in terms of handling that may be less complex for Opertuzumab, but I'm not certain about that.
All right. Why don't we go back? Any questions about that then? I think we can go back to the voting slide. Okay, so number 1 is, you remember, delivery mechanism and complexity, and number 3 is higher real world adherence, which means it's simpler than what we're comparing it to. All right, let's see, 1 more vote. Okay, show the results. Okay, 8 2s and 2 number 3s. All right, now I'm going to try to figure out from time management now. We are already starting to eat in, so to speak, to the lunch break before the policy roundtable. We have a number of these questions left, and I'm concerned we're not going to be able to get through them in a reasonable amount of time. So we're going to figure out a different way. We may have to come back to them when we open up instead of the policy roundtable, but we might be able to prioritize them in a different way, or even do them in offline voting, depending on how much conversation they might require. But I know that we're all going to need at least a half hour for lunch. So we're going to break now and reconvene at 1:30 Eastern, 12:30 Central. So I'm sorry, it's only going to be a 30-minute break. But at that point in time, we'll be able to figure out how we can manage the rest of these voting questions and the policy roundtable in a way to make sure that we get the best out of the time that we've got. Okay, so we will see you back in a half hour, and we'll take it from there. Is actually, we figured out a way to tailor the voting questions to be able to do them fairly quickly. So we're going to do a little bit more lumping and less splitting, and then we'll be able to pivot to the policy roundtable. So let's go ahead and get back to the last vote, or not the last vote, but where we were. We've got a few more to go. Again, I just want to check, and it looks like we do have all of the, almost all of the Midwest CEPAC. So Aaron Carroll looks like the only one who might not be back. But there he is. All right, we're all back. Excellent. Okay, so back to the voting question. Here it says, number one, the treatments, and I'm sorry, this one should be for both. No, this one we're still gonna vote on nadofaragene and Opertuzumab separately on this one. Will the treatment significantly reduce the negative impact of the condition on the family and caregivers versus the comparator? Or it will significantly reduce the negative impact of the condition on family and caregivers versus the comparator. Now, again, the comparator here is kind of a general idea of surveillance. So we're not asking you to compare it directly to Pembrolizumab or to cystectomy or to anything else. Just think about in terms of how, if it helps patients themselves, does it have a relatively large spillover effect on the family and caregivers in this instance? So that's really what we're asking about here. And let me ask one of the patient representatives if they're back with us as well, Karen or Stephanie. What's your experience, your knowledge of how the treatments in terms of whether they can help patients, what is the spillover effect, if that's not an inappropriate term to use, for the way that it can help patients and, sorry, not just patients, but their.
Well, this is
Karen,
Stephanie, and you know, the surveillance aspect of bladder cancer is pretty rigorous. You know, you do have to go in for cystoscopy, and that is on a regular schedule. So that obviously, if the patient needs to have somebody to get them there, that can be a big burden on family members, as well as just the general stress of not knowing about recurrence. So if you've got a treatment that's going to be effective, you're going to significantly impact the family in a positive way. They may still have to go back for the surveillance, but it wouldn't have that anxiety. And maybe Karen could speak to that a little better.
I mean, certainly a therapy that is less frequent, to be able to fit it into your work schedule if you're working, or like Stephanie said, if you're relying on a family member who might be out of town to get you to your appointments, which may or may not be locally. So certainly having fewer treatments and less frequent would be a benefit.
Okay, so I mean, and we've talked a bit about how nadofaragene has a distinctly different kind of delivery profile in terms of the number of visits versus other treatments. And even if you're thinking about surveillance, which would ultimately lead to other treatments, I guess we're kind of looking for that impact as well.
Steve, this is Alan. Could I ask a question?
Sure.
It was along the same lines. So it does sound like from what you just said that because we did have some discussion about some benefits that may be related to administration, as it relates to things like transportation. I assume it's okay to use that same thinking here, but as it might apply to a family member or a caregiver. Is that correct? And then I have a follow-on question if that is the case.
That is the case, very much so.
Do we have any insights, and I'm assuming that I'm assuming that for all of these, that for which there's travel associated with, with administration, that it's fairly typical for a family member or caregiver to go with. So is there, and I didn't see that, and maybe it was in the data and I didn't see it, I apologize. But is that a fair assumption that there's not like something about one of these that really you could go alone and do it and come back, but all of these probably have that same, they're not differentiated as to whether or not somebody would have to go with you as part of the in the office?
It's a good question. Would the clinical experts like to comment? Are there any differences? Are some of these treatments able to be delivered to a patient who can then drive themselves home, or are they pretty much always requiring a family member or caregiver?
I know that from our perspective, a lot of intravesical patients do get themselves to their treatment and then drive themselves home as well. It's just, if you're looking at a population you were mentioning earlier, age 72, if you're looking at people older than that who might need assistance getting out to the doctors, then that's really what I was sort of referring to in terms of, and I think what Karen was referring to in terms of bringing them into care. If they need to, if say you're an adult child who's taking care of a parent and you're still working, you need to take the day out of work to take that loved one to the, to their treatment. And the fewer days you have to do that, the better off you are in case you need it for something else when your loved one gets sick later down the road.
Okay, that's what I thought. Thank you.
Great. Thanks for the question. Okay, and some of that perspective. Why don't we go back to the voting slide? All right. So the question is about nadofaragene. Would we say it, 1, will not significantly reduce the negative impact of the condition on families and caregivers, or will, number 3, it will, and number 2 is intermediate, somewhere in the middle. Why don't we go ahead and vote? Maggie, can you let me know or us know what is the total voting denominator? Is Rachel back with us?
Yes, she is.
Okay.
Yes, I'm here, Cameron.
All right, great. So we should have 11. Is everyone still in the voting software, I hope? Because we're stuck on 10 here. All right, well, let's go ahead and look at the results. Okay, we've got 9 number 2 and 1 number 1. All right, let's go next to Opertuzumab. Okay, this one, again, exact same issues and that we just discussed. So I think we can go ahead and vote on this one as well. Okay, we should have at least one more then, because we had 10 just a second ago. Look to see if your result is highlighted in blue. That means it's being recorded. All right, we're having a little bit of a, there we go. Good. Let's grab those results while we've got them. Okay, very similar to the previous one. Good, well done. I think we're almost on to the last of these slides. This one, we thought we could lump the two together again, partly because the clinical effectiveness was judged, that we could not distinguish it between the two based on the evidence. So this is one, though, where we want to talk about whether they have an impact on improving the return to work or overall productivity in terms of their effectiveness versus the comparator. And I know this is hard because we're talking a little bit about you have to spend time in the treatment, but it's kind of, does this treatment have a strong effect or a relatively small effect on the ability to return to work? And again, we might ask the clinical experts if they have a quick word here. Is there a strong impact on returning to work for these patients when they're in remission versus when they're not?
This is Steve Atlas. I'm not aware that there's really any data in this area.
Right.
Obviously, for individuals, maintaining the use of their bladder could provide that ability, though we don't really know whether in fact these treatments will do that and for how long, though that obviously would be a hope.
John or Aaron, any comments on that?
This is John Gore. Sorry, it's saying that my video is disabled, but I agree. You know, I think this is a hard one to answer and would only be anecdotal at best. I mean, you know, if people have an excellent response to treatment, that does mean that at some point the intensity of their surveillance can decrease, and they can go from quarterly surveillance to semi-annual to annual surveillance, and so that clearly makes a difference. But you know, there's nothing unique about the actual visits that make them more or less likely to have to be out of work beyond the visit day.
Okay, thanks. That's very helpful. Stephanie, yes.
Just a quick comment, you know, for those patients that do ultimately have to have their bladders removed because of recurrence and progression, you know, if they are working, there certainly are some accommodations depending on the type of urinary diversion that they might need to have for catheterization of, you know, anything, or changing stomas. There's all kinds of potential complications that may limit or preclude them from working their regular schedules if they're not allowed, you know, adequate bathroom breaks to, say, empty a neobladder. There could be some other concerns that might have work limiting factors on there.
Yeah, that's a good point. I don't think many, even primary care doctors, don't see that many patients with kind of urinary diversions, and it can really make it difficult for patients because they always have to have a clean place to catheterize or something else, and it can be quite limiting. Dan, I'm sorry, do you want to say something?
Yeah, I just wanted to confirm what Steve said. We actually conducted a systematic review of the literature and found no information on this.
On the impact on work, you mean?
On the impact on work, correct.
Okay. Kelly, are you raising your hand? You are.
I am. So if there's no data other than anecdotal, how do we vote on this?
Well, one of the reasons that we have these votes is because we recognize that there sometimes could be data but aren't, or literally could not be data. And it doesn't mean that we don't want to send a signal if we feel that this is likely to be an important situation or consideration. If we think it should be, even without hard data, then this is our opportunity to do that. So some people do feel that it's important to have data to back up something like this, and that might affect their vote from a 2 to a 1 or a 3, but it's not a requirement that there are quote unquote data for people to feel that these could be likely.
What, can I make a comment on that?
Yes, and then Tim, and yes.
Oh, sorry, I didn't want to jump ahead of anybody. I don't see the hand raising thing on my screen. Oh, there it is. Raise my hand. I can do that.
Alan, why don't you go ahead?
Okay. Well, we do quite a bit of work in this area, so I would just say one way to think about it is going back to that, mode of administration concept. And I don't know that this is true, but the assumption could be that for working age individuals, if there's less frequent travel to appointments because of the the timing and frequency of administration, that also would have less of an impact on your ability to you wouldn't have to take off work as much or as frequently to go for those appointments, assuming that people of working age who are still working, not of working age, but anyone who's still working would be still working at that point of being unresponsive and being in that stage of therapy, which I don't know if that's true or not. That's a question for the clinicians. But that's, Kelly, how you could maybe extrapolate from some other information about the logistics and mode of administration that where you could maybe postulate some potential benefit around work disruption, similar to how you would do so as it relates to transportation burden. Those two tend to interconnect. If the transportation burden and you're still working, presumably you would also have less work disruption because those things tie together.
Great. Tim, yes.
I'm glad that Kelly raised this question because I've had this question all along, and many of the questions, because the question's worded as will not have a significant impact, which tends to suggest that we've done a study and we found insignificant effect, which suggests empirical evidence is lacking versus what I heard from
Excuse me, can you speak up a little bit? Thank you.
Tim, I think I caught it. You're on mute now, but I'm
Oh, no. Can you hear me better now? So I think, the point is that it suggests we did a study was insignificant versus we don't have any studies at all. And I wish that there was a choice that says insufficient evidence on a lot of these questions, because I would have liked to have voted that way sometimes. So maybe we can have that discussion later, or you all can think about that, because I'm going to be forced to make a choice here. I know that sometimes it's a judgment call, as we just heard, but it's suggesting something about an empirical evidence.
Well, actually, in this case, I think we could certainly substitute the word substantial in your mind. If significant kind of makes you think that it's more statistical significance or something.
That's the way I read it, as an empirical.
But I think the times we have had actual evidence of the impact of treatment on work productivity is essentially zero. So you can say we could have data. It's not impossible, but what we're saying is that in that world in which we don't have evidence, we still want to and hear testimony and kind of weave that into our thing.
I think I'm making a broader comment about other questions too. I would have liked to have had a question in a category of insufficient evidence.
I'm afraid I'd make it too easy for you, Tim. All right, let's go back to the voting slide. And with those helpful comments on multiple aspects of this question, let's go ahead and vote. Number one is it will not have a significant impact on improving the return to work or overall productivity. And number three is that it will. All right, we have all the votes already. Thank you. Okay, 3 number ones, 7 number twos, and 1 number 3. All right, I believe that is our last voting question. In some ways, I've never felt so happy to be done with the votes. I don't know about you.